Good morning or good day. So, dear speakers, dear attendees, I would like to wish you a warm welcome to the now traditional ELPA symposium during EASL ILC. I'm very pleased to see some of the attendees here, and we really do expect some more to come. As we have seen in the previous days, we are soon about to enter a new era of interferon-free treatment for hepatitis C. However, many people are already very ill and cannot benefit from available treatments. Many of these patients already suffer from advanced liver disease and comorbidities such as HIV co-infection, renal or heart disease. They are at the highest risk of dying within the next years if their hepatitis C infection is not cleared very soon. These patients die while they are hearing about potentially life-saving new medicines which will not be made available for them in time. These patients need better drugs now and cannot wait for approval. For this reason, we have chosen the topic of this year's symposium to be compassionate use in hepatitis C, saving lives of patients who cannot wait. I cannot stress enough how urgently we need compassionate use programs. New promising medicines must be made available to patients who need the most. Risks and benefits need to be weighed carefully. Therefore, I am delighted to welcome expert speakers who will discuss compassionate use from the view of doctors, health authorities, regulators, and patients. I would like to welcome our moderator, Professor Thomas Berg from Leipzig, Germany. Thomas, please, the floor is yours.
Well, dear ladies and gentlemen, my name is Thomas Berg. I'm the head of the section of Hepatology in the University Clinic in Leipzig, and I really would like to welcome you on behalf of our experts sitting here, and I would like to introduce them in a minute on behalf of the patient organization and patients by themselves. And I especially would like to welcome all the patients here in the room, the people from the industry, and all the others. First of all, I would like to give you a very brief overview of our agenda and also introducing the different people who are giving the talks. So the topic of our talk is really how we can use compassionate use in patients with chronic hepatitis C virus infection, and on this topic, saving life of patients who cannot wait. And I'm very happy that we can get views from different people involved in this field. And first of all, I would very much like to welcome Professor Prati from Italy, giving the EASL view on this topic. This is followed by the patient's view and so-called this special patient population situation, patients who cannot wait, patients with comorbidities, and in this respect it's a patient with a co-infection. Then, and I'm quite happy to welcome Filip Josephson from the EMA, who will show his perspectives on the issue of compassionate use. And then we have the infectious disease specialist, and this is Professor Prati, and I also would like to welcome him. We first intended to have the Bulgarian Deputy Minister of Health with us, but this is now replaced, and I'm quite happy to welcome Dr. Stanimir Hazardjev, and he's the Executive Director of ELPA, so very welcome. Then we have at the end a living example how compassionate use may work, and I would like to welcome Mr. Gardini, and at the end I would like to give a very brief summary, and this will lead us finally to the panel discussion, where you're really invited to give all your questions to the panel that we try to answer. So let me start with a very brief overview on where we are now and what we would like to discuss. And you are aware of the global prevalence of hepatitis C virus infection, with an estimated 170 people being infected. And you see the different numbers of patients being affected around the world. So there's clearly a difference according to the geographical region. And most recently, and these are data from the US, it has been shown that probably, let's say, the danger, the importance of Hep C virus infection was underestimated. There was done a lot in order to treat, to prevent the problem of HIV infection, and this resulted in a decline in mortality over the time, at least in the US, but probably also in other countries. But at the same time, Hep C virus infection was neglected, and these curves now crossed, and there's an ongoing increase in hepatitis C mortality. On the other hand, it's quite clearly shown that we have effective treatment, and that by this effective treatment, we can reduce mortality. So detecting the patient, treating the patient, may ultimately lead to a reduced mortality of hepatitis C virus infection. Well, while we are here and discussing compassionate use, this is the future landscape of hepatitis C virus treatment, and there are two directions of interferon-containing regimens with new direct antivirals, and quite spectacular, the interferon-free regimen, showing that with a quite safe regimen, you can quite effectively cure many patients. So there's a lot more to come, and we have to see how this will change and how it's access to different countries. And that's the last point I would like to make, that what we are discussing here is access to treatment, and giving again the geographical distribution of Hep C virus infection in the different areas of the world. It's quite clear that especially in those patients with the highest hepatitis C prevalence, and probably with the highest need of treatment, the access to even standard of care is limited. And with this first introduction, I would like to hand over to the view of EASL on compassionate use, and I would like to welcome Professor Prati. Please.
Thank you, Thomas, for your introduction. I'm Daniele Prati. I'm here to represent the EASL governing board. And I have to say that actually EASL has not an official position with regard to the compassionate use. However, we have an essential mission of EASL, that is to promote liver research and to improve the treatment of liver disease throughout the world. So in this context, even if we do not have a specific position with regards to access of patients with severe liver disease to antisense therapy, we welcome the compassionate use programs for the patients who are at risk of progressing beyond treatment boundaries. For example, decompensating or experiencing severe viral reactivation after liver transplantation. These when the risk to benefit ratio of treatment is presumed to be positive. But what we are talking about when we are speaking about compassionate use is a treatment option for patients suffering from a disease for which no satisfactory authorized alternative therapy exists, or who cannot enter into a clinical trial. And in this regard, so if a drug exists, so has been developed, and the patient cannot enter into trials or direct prescription of the drug, it can benefit from alternative access. And this access, this has been described in different ways throughout the world, while the US prefer to call them expanded access programs. In the EU, the compassionate use programs is still a valid definition, but there are also other definitions, including named patient programs, named patient supply, and the temporary authorization of use, especially in France. However, I think that one of the things that is important to distinguish in order to have a practical view is to divide them between the named patient compassionate use programs, and you can see in this column on the left, and in the cohort compassionate use programs. These two programs are generally a little bit different because, firstly, because of the patients that are treated, that are typically less than 50 patients in the first one, but up to several hundred patients in the other one. And there are also some difference with regard to the regulatory procedure, the prescribing physician or company regulations, and also with the review time, which is generally shorter for the named patient, but can take several months for the cohort programs. There are, of course, some issues and barriers, and I'm here probably especially to illustrate them to compassionate use at the present. The main ones, I think, are the lack of the uniform legal framework within the European member states, and also safety issues. There are other issues that are the concerns of potential damage or delays to clinical trials deriving from compassionate use programs due to competition with these trials. There are, of course, marketing priorities and concerns by pharmaceutical companies, especially when nothing is, there is no very thorough knowledge of what adverse events are to be expected. And there are also some economical and reimbursement issues. So the question is who pays and how the different national health systems or insurance systems can afford expensive new treatments. And of course, this last point differs in different European countries. So the lack of the uniform legal framework in EU member states is summarized here, although the EMA guidelines on compassionate programs do exist, and EMA opinion on a program can be applicable for all the member states throughout the EU. The member states are not, I would say, legally bound to follow this recommendation, because the approval on any project in the single country is a national responsibility. And in addition, the regulatory framework are very different in different countries, and the main difference are the eligibility conditions, the procedure for regulation, and the review times that are made very different. And I suggest you, even not to go in detail in this complicated slide, to read this review article which appeared a couple of years ago in Pharmaceutical Medicine, that show what are the main differences with regards to these aspects in the different states. But what is compassion? And this is the definition of the dictionary, is a sympathetic consciousness of others' distress together with a desire to alleviate it. And if you wanted to go in a much more detail, I suggest to read this book, which focuses very well on the patient-physician relationship. And they actually describe compassion like a mixed feeling between empathy and sympathy, empathy being the most appropriate way of defining a good patient-to-physician relationship. And as you can see here, empathy is characterized by high cognition, so high knowledge, and low to average emotion. Compassion is characterized by average emotion, and I would say also average cognition. And this is what probably the main point to be considered when we're talking about safety. This slide is just an example of the most important, I would say, compassionate use programs among those recently conducted, has been conducted in France, and after Daniele will show you a complete overview of this program. But what this compassionate use program that was about the use of peginterferon and ribavirin with newly aced delaprevir and boceprevir showed an excess mortality in the arm treated with not in the arm, among the patients who assumed these drugs. And of course, these side effects, the excessive side effects, could not be predicted before starting the trial, because before starting the program, because there was no trial on cirrhotic patients. So there are safety concerns. In patients with advanced liver disease, both the efficacy and the safety profiles can be less favorable than in clinical trials. And in compassionate use programs lacking this data, the potential risk and benefit for patients of treatment cannot reliably be predicted. But who decide what is a positive benefit to risk ratio in single patients who are at risk of severe outcomes? Maybe that the patients and physician perspective are different, and in fact this is what we have learned from the literature. These are studies conducted in other fields. This is in the Parkinson, but here you can read what Mary Baker, the patient editor of the British Medical Journal, said. For Dr. Parkinson's disease is mostly above the neck, something to do with the substantia nigra, and for patients it's mostly below the waist. Can I get my knickers on? Will I be continent? There are also disagreements between patients and physicians in other fields. So this is, for example, the maximum number of bleeding considered acceptable in 100 patients who had atrial fibrillation and took aspirin to prevent stroke. And as you can see, the maximum number of bleeding accepted by patients is higher than that accepted by physicians. And for multiple sclerosis, the more important domains are those of vitality, general health, and emotional role limitation, while the patients have other type of priorities. So, in conclusion, the definition of uniform policies of compassionate use programs across different countries would be desirable. Defining the risk-benefit ratio for patients with severe liver disease potentially candidate for compassionate use programs is complex, require a prudent, open and transparent discussion between patients and physicians. And frequently the patients are prepared to volunteer to expose themselves to increase the risk because of the severe prognosis. The entire decision process for compassionate use programs requires specific regulations to protect the implementation of clinical trials and to limit the impact of liability concerns and financial marketing issues on decision of compassionate use programs implementations. These programs are not specifically intended to provide data on safety and efficacy, but when they are appropriately designed, they can be useful to design future trials in particular patient populations. And I would remind, and this is most important for some of the countries of the EU, that compassionate use programs are not a solution to solve local delays in deciding on the criteria for healthcare system reimbursement in this country. This is particularly important because, especially in my country, we have recently experienced this kind of problem. So I'm sorry that I have to leave after this presentation because there is the business meeting of the EASL board in the other room. I hope anyway to be able to come back for some discussion in the end. Thank you very much.
Daniele, thanks a lot. And I think we move forward within our program, and it's a pleasure to introduce now Louis Mendao. Please go to the microphone, and he will give a talk on the HCD compassionate use programs for people living with co-infection with Hep C and HIV infection.
Is it on? Yes. Good morning. I'm in a very difficult position. I thought it would be very easy to talk about this, and it turned out to be quite difficult. Also because I will speak before some speakers that I would like to hear first. One of the things that I'm convinced of is that we need to work together fast and well to save lives. I heard very attentive the president of ELPA, and I know there is a small fraction, but with many of my friends in there, that really cannot wait for the time that the drugs will be normally available. And this has probably no impact in the big numbers, but there is a terrible impact in the concrete individual lives of people. do I change these? God. Okay. Okay, so I'm an HIV/HCV patient, a male, heavy smoker, old, diabetic, lipodystrophic, with non-alcoholic fat liver disease, cirrhotic. I don't know if I'm still compensated. I'm afraid to go there. Null responder to PEG-RIBA. I'm genotype 1A, CT. I'm under successful combination heart therapy for 17 years, and I still have something very strange called Addison disease. Probably I'm a little biased towards interferon-free regimens and not fitting the usual criteria for exclusion, for inclusion in clinical trials. But I'm convinced that I could take the risk to be treated in the near future if I could have access to or land-based or compassionated specific programs. The drugs that I need and that my doctor also thinks that I would need will normally be available in my hospital for the next, not available for the next 3 years, and with the financial situation in Portugal, probably much, much longer. I would like to thank ELPA for the invitation and the ELPA commitment on access for patients with advanced liver disease and other comorbidities. I'm convinced that we share that there is a revolution going on HIV treatment and cure. I'm convinced that the collaboration between informed treatment activist patients and patient organizations across Europe and the US did contribute to change radically the regulatory pathways for approval of new drugs and new clinical trial designs to be accepted. That's also why I believe that doctors and pharmaceutical companies and researchers should and need to work with us, because we did contribute greatly for the fast movement on the new regulatory pathways for this. We need to translate the ongoing process in the safest access for those in the most urgent need. Are people with HIV/HCV a separate group from these with no HIV? I think it's only partially. Usually, co-infected people progress faster, the rates of cure are smaller. To use HCV drugs, we need specific DDI information, but as the others, we can be easy to treat, healthy people, and we can have all stages of diseases. And though we are less than 10% of all the HCV patients, due to the faster progression, we have a disproportionate number of people with advanced disease. After and if the DDIs are solved, co-infection should not be an exclusion criteria for early access programs for clinical studies on cirrhotic, compensated or decompensated, and pre or post-transplanted, compassionated use programs or name-based access, in my opinion. Some provocative statements. HCV, it's now an easy-to-cure viral infection. We have on phase 2 and phase 3 clinical trials a set of drugs that could, used in the right way, cure virtually all HCV patients. Viral eradication is beneficial for all patients with advanced disease. The very heterogeneous groups of people with advanced disease need to be referred and have access to reference clinicians and centers. And I will finish quickly, but I would just like to reinforce this point. I believe that we need that virologists, that infectiologists and hepatologists do collaborate. I believe that This is a viral infection, but for people with a very advanced liver disease, we really need specialized care, and we need good collaboration between the different experts in our disease. We need regulators to issue guidance on compassionated, needed, and acceptable programs. I know that Filip will speak after and probably say that will be no time, but we need to discuss that. We need companies not to hold access to their drugs on compassionate and name-based use, that regulators, physicians, and patients agree on the risk-benefit. And we need commitment and guidance from clinical societies and the best among the researchers and the physicians. And we need to work together and fast and to have consensus written positions. Because even if we have different regulatory pathways in the different countries and different situations, without EASL guidance, without NEMA guidance, without some of the top stars of the physicians writing something clear about what should be needed to have access, I don't think that we can fight in our countries for access. We also need to have access to drug combinations from different companies, and I think this can be a big challenge, and best compassionate programs for the compensated and pre-transplanted people without interferon. I would like to thank, though it's unfair so many others, for people that that I admire and have worked together and did inspire some of the work that we did. And this is, first of all, of course, Ivan Gardini, Maxime Juniac, Jules Levin, who has a terrible, I don't remember the name in English, and Tracy Swan. Thank you.
Thank you very much for these quite clear words. And now it's a pleasure to introduce Filip Josephson, and he will give the view from the regulatory perspective from the
So I want to thank the ELPA for inviting me to present the regulatory perspective on this very important issue. And I will speak about the European Medicines Agency, the pan-European regulatory perspective, because as Dr. Prati already referred to, the legal situation and legal framework surrounding compassionate use programs and early access in Europe is very heterogeneous and very and differs between countries to a considerable extent. So I'll begin by trying to say a little bit about how the European regulatory system works, because that's perhaps not self-evident. So the European Medicines Agency is a decentralized agency of the European Union. It's located in London and is responsible for the scientific evaluation of medicines developed by pharmaceutical companies for use in the European Union. The CHMP, or Committee for Medicinal Products for Human Use, is the ultimate scientific decision-making assembly at the EMA. It consists of representatives from each European Union national agency. Now, the decisions that the CHMP take are generally based on assessments and recommendations generated by national agency assessors. And I am one of those. I work for the Swedish Medical Products Agency with the assessment of antiviral drugs. Now, the responsibilities, regulatory responsibilities in Europe are divided in a particular way between the pan-European EMA body, representing, so to say, an umbrella organization of all the national agencies on the one hand, and each national agency on the other. And the areas of jurisdiction, or the sort of the contents of the jurisdiction is divided in a way that might not be entirely self-evident either. Decisions concerning the approval, conditions for approval, and post-approval follow-up of new antivirals are taken by the CHMP. And the CHMP decisions pertain to the entire European Union. Decisions on clinical trial applications, however, are taken by the national agencies alone or cooperatively through voluntary harmonization procedures, and pertain to the area of jurisdiction of each national authority, that is, to each respective country. Decisions on the approval and implementation of compassionate use programs, as well as other forms of early access, such as availability on a named patient basis, mentioned by Dr. Prati, are principally the responsibility of national agencies in accordance with the various national legislation. One could consider that there are basically 4 forms of early access, that is, access to treatment with a drug prior to its regulatory approval. The most important form, of course, is clinical trials, which is where the evidence of the efficacy and safety for the drug is generated, and which is necessary to use drugs in a good way to get maximal benefits. And I cannot but repeat Dr. Prati's point that when we look at other points of early access, it is extremely important that these do not compete with clinical trials or in some way compromise the ability to make good clinical trials. We can also use the term expanded access programs, which from a European regulatory point of view would be understood as clinical trials and treated as clinical trials with primarily a safety endpoint. Then we have compassionate use programs, which I will talk, which the rest of my talk will be about. And then the named patient basis, where a single physician approaches a company to procure the drug for his patients, and the regulatory involvement in such procedures varies between European countries. So, compassionate use programs can only be put in place for medicines that are expected to help patients with life-threatening, long-lasting, or seriously disabling illnesses who currently cannot be treated satisfactorily with authorized medicines, or who have a disease for which no medicine has yet been authorized. And the compassionate use route may be a way for patients who cannot enroll in ongoing clinical trials to obtain treatment with a potentially life-saving medicine. Dr. Prati mentioned this point, which of course is very, very important in evaluating the benefit-risk of instituting a compassionate use program. This pertains to drugs that are not approved, and they're not approved because the evidence of efficacy and safety is yet not sufficient for the drug to be approved. That means that at this stage of development of a medicine, what is known about the medicine's safety may be limited. Generally, toxicology studies, that is, for instance, animal studies, will have been completed and analyzed, and early pharmacokinetic studies will have been completed. Now, pharmacokinetic studies are studies on the relation between the dose that you give of a drug and the exposure that you get. That is, how long this stays in the body and at what drug levels. And when we're talking about patients with advanced hepatic disease, clearly this is a very, very important point. And it is important, if you go into a compassionate use program in patients with compromised hepatic function, it is very important that there are data on the pharmacokinetics of the drug or drugs used in the population that is targeted. Furthermore, there may still be uncertainties about the best way to give the medicine to patients, such as the exact dose and the dose frequency, or with hepatitis C regimens, perhaps most importantly, how the duration of treatment and how to combine drugs to get the most out of them in patients with advanced liver disease. And it should also be recognized that the safety database, the knowledge about how safe this drug is, both in patients in general and in patients with advanced disease, may be limited. So, compassionate use and early access is mainly under the jurisdiction of national authorities. However, the European Medicines Agency have one instrument concerning the compassionate use, and that is in accordance with the Article 83 of European Commission legislation. The object of Article 83 is to facilitate and improve the access of patients in the European Union to compassionate use programs, to favor a common approach regarding the conditions of use, the conditions for distribution, and the patients targeted for the compassionate use of unauthorized new medicinal products. And importantly, to increase transparency between the member states in terms of treatment availability. For a drug or drugs to be eligible to be treated by Article 83, apart from the general conditions for compassionate use, the medicinal products should either be the subject of a marketing application or undergoing clinical trials and would be approved through the so-called centralized regulatory procedure. This is applicable to all new antiviral substances. And these programs are intended for a group of patients. They define a target population, and this is as opposed to the previously mentioned named patient basis form of early access. With Article 83, the CHMP, that is the scientific decision-making body of the EMA, makes a recommendation concerning a particular compassionate use program on the basis of available documentation. However, this CHMP opinion and recommendation is not binding on the member states. However, to quote the text of Article 83, the member states should take account of any available opinions, that is, of the CHMP. The recommendation complements national legislation, which it does not replace. And the recommendations are ultimately optional and are only implemented by the member states that wish to use them for their patients. So, to start an Article 83 procedure is started if a European Union member state's national authority envisages the need to make a medicinal product available for compassionate use. And if so, the national agency will notify the European Medicines Agency. Companies should not directly contact the European Medicines Agency for CHMP opinion. Companies may, however, at their own initiative, inform the EMA of compassionate use in member states. Now, the sad thing about Article 83 is that it's hitherto only been implemented for two medicinal products, that is for the intravenous products of oseltamivir and zanimivir for use in seriously ill influenza patients. And it would be very interesting if the Article 83 could be used for an hepatitis C program. Lastly, just to remind you of the principal requirements for compassionate use. There needs to be access to documentation about the drugs. Regulators need to be able to make a decision on the benefit-risk within the target population, notwithstanding the fact that this may, because of the early stage in drug development, be rather uncertain and based on limited data. Then, of course, there needs to be access to the drug. And I think it's important to point out that European regulators have no legal provision to force a company to provide early access through compassionate use. Finally, I would like to mention that if you want to know more about the European Medicines Agency and compassionate use, there is information at the EMA homepage where you can search with the term compassionate use. Thank you.
Thank you very much. And now it's a special privilege to introduce Professor Daniele Dhumeaux. He's a professor of hepatology at the University of Paris and chair of the French Masterplan for prevention, screening and management of viral hepatitis. And he's going to give you the French experience with compassionate use. So please.
Thank you, Thomas. Thank you for the invitation and the support of Rembrandt's angle. This is in Berg, not in this city. And the title is HCV Compassionate Use Program, the French experience, well illustrated by our CUPIC model, and Daniele Prati spoke about that. And this is a well-known CUPIC, and the CUPIC combines both French and compassionate, and therefore is perfectly adapted to the speech. Compassionate use of protease inhibitors in viral C cirrhosis. This is a National Multicenter Observatory in the setting of ETU. ETU is our French word for Early Access Program. ETU, temporary authorization for use. And this CUPIC was combined with this ETU for evaluating of real life. It's very, very important, this term, safety and efficacy of triple therapy, including teriparatide or boceprevir associated with PEG interferon plus ribavirin in HCV genotype 1 patient with compensated cirrhosis, very specific population, who were not responder to previous dual therapy. And the treatment was either triple therapy with boceprevir or triple therapy with teriparatide. For teriparatide, 12 up to 48, and for the boceprevir, 44 weeks of treatment after the leading phase of 4 weeks. And we had from this study very, very important information due to the fact that this is a very specific population and not found in usual pivotal trials. And we have information about the safety, and you see that the high number of side effects, serious side effects found in these patients, more than 50% of patients have serious side effects with premature discontinuation for treatment due to these side effects in 21 or 14% of these patients. It is very impressive due to the specific type of patients. And from this evaluation, we could identify the two main biochemical or blood factors associated with the occurrence of death or severe complication. And you see that when platelets are lower than 100,000, and the albumin was when albumin was lower than 35 grams per liter, we have a significant side effects. It's not very important when we have only one of these two factors, but when we have two, these two factors, more than 40% have very, very severe complication, and this could be represent a contraindication of triple therapy in this case. And as far as efficacy is considered, we have the presentation yesterday, I think, in general session from Hélène Fontaine, and you see that there is no very important difference between the two drugs, the triple therapy, with a global cure of infection, not disease because they have cirrhosis, a cure of infection in 40% of the patient. With we know that best response in relapser 53, 51, and in partial responder we have 33. 32 and 40. It is not. It is very important result because this patient has non-responder to previous and very, very severe disease, and the fact that to have a cure of infection is nearly 50% of the patient is really significant. And we have a French ETU. Early access program in France since 1994, nearly 20 years ago, and more than 1,000 medicinal products have been assessed since this date. The availability is obtained 10 to 12 months before a marketing authorization application, and therapeutic areas where oncology, hematology, central nervous system disease, metabolic disorders, infectious disease including, of course, HIV infection, and viral hepatitis. We had, from this date, 20 years ago, very strict criteria for granting this ATU. The first, the product is medicinal product, not a preparation. Two, ATU is given for treatment, not for investigation. But you can combine investigation with such ATUs. It was the case of Coupe, of course. There is no market authorization. This has been applications, that's been said. The patient cannot be included in clinical trials, this has been said. The disease is serious and or rare, and there is no available alternative therapeutic method. And efficacy is very, very important. Efficacy and safety are presumed, and benefit is expected for, of course, for the patient. But this has to be proved by clinical trials. And we have two types of ATU in France, nominative and cohort ATU. The nominative is for one patient on a named patient basis. We discussed about that. And it is the request and responsibility of the clinician. By contrast, cohort ATU is for a group of patients with well-defined the hepatic disorder and applied by the company commitment to submit a marketing authorization. In both cases, we have a follow-up of patient and data collection according to a protocol for therapeutic use. And when we plot these items according to the amount of benefit-risk evidence, we see a clear relationship between this item from phase 1 to nominative ATU, cohort nominative, and marketing application. And in general, nominative ATU precedes cohort ATU, but in close connection with the implementation of clinical trials. And we have success and limitation. The success is the ATU system extremely useful for public health needs. It's strongly supported by patients and physicians. It's controlled by a competent authority. In France, it's the National Agency for Medicinal Products. You can contact this agency and, of course, the European agency. And the risk, first, it was mentioned previously, to slow down clinical trials and marketing authorization application, and mainly to overestimate efficacy and to underestimate safety, especially in very population with very advanced liver disease. And in France, we implemented some months ago nominative ATU for patients having developed severe disease recurrence post-transplantation, and a cohort ATU is in progress, probably in next September, for patient waiting list transplantation and waiting liver transplantation, and patient having developed severe disease recurrence post-transplantation. The drugs would be sofosbuvir plus ribavirin, but I think that in European countries we could have new protocols for evaluating this interest of compassionate use. Thank you very much.
Thank you very much for this really helpful review of the data you have with this early access program. And you have heard now a lot about the patient who cannot wait. And I'm really happy that Professor Massimo Prati, who is an infectious disease specialist and has also a lot of experience with HIV infection and the co-infection, and of course Hep C virus infection, would like to give you a kind of a definition. What is a patient who cannot wait? So please.
Thank you very much. First of all, I wish to thank the ELPA, the EASL for giving me the opportunity to share my experience, my ideas with those of the patient. And these are my disclosure. So I think that we are facing, because we have already seen the problem with co-infection, so I will not mention co-infection, but I think we have at least 3 groups of patients with the highest unmet need. Patients with cirrhosis, patients without response to previous therapy, and patients intolerant to interferon. We will start with patient with cirrhosis. The beneficial of treatment of patient with cirrhosis is shown by this Italian paper, showing that in 10 years, but also at 5 years, the proportion of patients with survival is, with sustained virological response, the survival is 100%, is very high. And the proportion of patients with failure without a sustained virological response to treatment, there is a substantial number of deaths. And the efficacy also of the more advanced triple therapy in patients with genotype 1 and cirrhosis is lower than in patients without cirrhosis. As you can see, these are the results of registrative trials in relapsers and partial responders with the two drugs which are now available. And these are the results that you have already seen in the CUPIC trial and real-life trial, where the results were probably lower, even lower. And also, as you have seen in a CUPIC trial in patients with cirrhosis, also the safety was different in the real world, taking into account only patients with cirrhosis in comparison with treatment-naive and treatment-experienced patients, including all the other patient population. And we have seen that also in some group of patients with cirrhosis, the probability of sustained virological response is equal and even lower the probability to have a very severe adverse event as a severe infection, decompensation, or death. And if we look at the old data about the treatment of patients with decompensated cirrhosis with the standard of care, interferon ribavirin, the results were disappointing, with only 24% of patients showing a cure, a sustained virological response from a virological point of view. But in this paper published in Journal of Hepatology, you can see that in patients with decompensated cirrhosis at the end, the probability of an infection or a severe infection was very high during treatment in comparison with untreated patients. And also there are some preliminary data on the treatment with triple therapy, interferon, ribavirin plus boceprevir or telaprevir, in patients with decompensated cirrhosis and waiting transplant. These are interim data showing that at 12 weeks there is a high rate of patients with undetectable SCVNA, but also there is a percentage, very important percentage of patients with very severe consequences, decompensation of very severe adverse events. So the patient with cirrhosis has the most urgent need because response is reflected by an increase in short-term survival and quality of life. There is in this patient population, the response to treatment is lower, and there is the highest rate of side effects. These side effects seem to be reasonable in patients with compensated disease or in patients without advanced disease. But in some patients with advanced disease, even if compensated, the chance of death or hospitalization are greater than treatment success with the current therapies, and treatment is, in my opinion, not indicated in the compensated patients. But we have some data showing that with interferon-free therapy, some drug companies during the phase 2 and phase 3 trial pushed the envelope treating with the interferon-free therapy patients with cirrhosis. You can see here a small experience from Berg showing that the rate of sustained virological response to a combination of ribavirin with 2 antivirals was the same, even with small numbers in cirrhotic versus non-cirrhotic with genotype 1b. And in addition, more robust data have been presented in this Congress and have been recently published in New England Journal of Medicine. With sofosbuvir, there are data on 153 cirrhotics showing that using sofosbuvir together with pegylated interferon and ribavirin for 12 weeks, the rate of sustained virological response in cirrhotics is 80%. Using sofosbuvir plus ribavirin for 12 weeks, the rate of sustained virological response is very high in G2 naives and also is lower in G3 naives. But increasing the duration of treatment and treating also cirrhotic patient experienced or intolerant, the rate of response increased. So even with the interferon-free therapy, it seems to be feasible to treat even patients with decompensated cirrhosis, and the French ATU probably will give as soon as possible new data on the treatment of these patients. Another group of patients are patients without a response after previous therapy, double or triple therapy. You can see here, these are the very good results with boceprevir and telaprevir in patients without response to treatment. And you can see here that in patients genotype 1 naive, at least 1 out of 4 of patients treated with triple therapy has no response. In relapsers, this rate is very low, but is higher in partial responders, and the majority of new responders, unfortunately, do not show any sustained virological response. If you look a patient without response, even genotype 2 and 3, which are different but are considered easy to treat genotype, the rate of patients without sustained virological response is 29% in genotype 2 and 28% in genotype 3, with an increase of this proportion in patients with genotype 3 and cirrhosis. And another important problem in genotype 4, where the rate of response to double therapy is very low, less than 50%, 41% and 42%. So, in summary, the majority of our treated patients probably do not obtain a sustained virological response. More than 40% are without a response to the current therapy, and with this range between 60% in genotype 4 and 30% in genotype 2. For this patient, there are some new data, interesting data in small number of patients, showing that using pegylated interferon plus 2 antivirals, there are very good rate of sustained virological response in a small group of patients, and this is a good option, but still includes interferon. But recently in this Congress, we have seen some data about the treatment of null responder without cirrhosis with a combination, a cocktail of different antivirals, showing a rate of sustained virological response of cure that is very high and very interesting. So there are promising solution also for this patient. And also from data combining in a small number of patients 2 drugs which will be available maybe in the next year, we have seen here that in patients with mild fibrosis, the sustained virological response 8 weeks after stopping these 2 drugs seems to be very high, combining these 2 drugs without interferon in patients without response to treatment. And also, there are very small experience showing that combining 2 antiviral plus minus ribavirin, we can also observe a sustained virological response is patients who fail telaprevir and boceprevir, triple therapy genotype 1. And in addition, again, in genotype 2 and 3, we have the data from the sofosbuvir study, the fusion study, which have been published on Lancet, showing that also in this group of patients, the combination of sofosbuvir plus ribavirin may obtain, especially in genotype 2, patients who fail prior treatment, very interesting rate of sustained virological response. Finally, the last group is the group of patients who are intolerant to interferon. You can see here the situation at the VA, taking into account that 100% of patients with hepatitis C, only 36% of patients has no contraindication to HCV treatment and has been tested for genotype. So the majority of patients with hepatitis C, a great number of them cannot afford interferon. So in patients intolerant to interferon are actually the missed target that could change completely the landscape of treatment. And there are interesting data, some of them have been published in intolerant interferon in Japan or genotype 1b, showing that in this patient the usage of 2 antivirals without ribavirin may obtain a sustained virological response in 64%. But these patients are difficult to treat also with antivirals. You can see here that null responders show a sustained virological response rate that is arithmetically higher. This was because there was a relapse in these patients, and in this patient probably because comorbidity, drug-drug interaction, or problems without adherence, the concentration of the 2 drugs, so that the adherence to treatment probably was very low. And this was the reason for the failure. And recently, once again, with sofosbuvir, we have seen some data in patients unwilling or unable to take interferon, and the rate of sustained virological response on interferon-free therapy with 2 drugs was also very promising. Finally, I think that we have to take into account that there is a paradox in the development of new anti-HCV drugs. We have seen here very interesting data. I have showed you many data obtained in easy-to-treat population with a lower urgent need. Patient with genotype 1b, naive, non-cirrhotic, without HIV co-infection. We have seen few studies in difficult-to-treat populations with the most urgent need. Transplanted patient, decompensated cirrhosis, null responder, genotype 1A, and HIV positive. And all these drugs will be marketed and are marketed with a very high price. So in some countries, in some systems, the cost effectiveness of the treatment will be the best in the sickest patients, but we are moving to have access to this therapy without enough data from phase 3 study in this patient population. Thank you for your attention.
Massimo, thank you very much. And we move forward in our agenda, and it's a pleasure to introduce Dr. Stanimir Hatatchev, and he's going to give you the perspective of ELPA. Please give me.
I'm Bulgaria. Thank you very much. First of all, I would like to apologize on behalf of our Deputy Minister, Ms. Slava Dimitrova, who has some healthcare issues, and she asked me to present here on her behalf because she cannot participate personally. Luckily, I'm co-chairing actually the Bulgarian National Governmental Working Group on the development of the National Hepatitis Plan in my country. So the purpose of my presentation would be to bring another perspective, a perspective of another country on how compassionate use can look like. First of all, some of you probably know about one of the projects that ELPA launched last year. In November, ELPA launched the so-called European Hepatitis Index project. In this project, together with Health Consumer Powerhouse, we were comparing the 27 EU member states, plus Switzerland, Norway, and Croatia on different indicators concerning hepatitis. Not surprisingly, as we heard the presentation from France is actually ranked on the first place. Many reasons for that, but obviously compassionate use and early access programs is one of those reasons. Where Bulgaria stays in this ranking list? Bulgaria is actually on 21st place after Malta and before Greece. And among the new EU member states, Bulgaria takes 5th place. For many reasons. We have identified in this project some good practices and some weak points, like lack of vaccination risk population, free and anonymous hepatitis testing and counseling, lack of ALT tests routinely by GPs, screening fundings, and other weak points of the Bulgarian system. Of course, we have identified some good practices like the universal infant HPV vaccination since 1992 and some other good practices that we try to identify from each of those 30 countries in order to be available for the other countries who really want to take actions. Based on the result on the hepatitis index, but also because of the pressure put by the experts locally and the patients' organization, and because of the willingness of our government, Bulgaria actually became one of the few countries in Europe that started the development of its own national hepatitis plan. This is a result of a successful collaboration between the healthcare institutions and the non-government organizations and the experts. And now I would like to present how compassionate use is addressed in the Bulgarian National Hepatitis Plan and what is the current legislation in our country, to see what's the difference with France. How the National Hepatitis Plan was started, as I told you, there has been for many years quite a lot of pressure to the health institutions in the country. But we were lucky to have an open government and people who really politically committed to have the Bulgarian National Plan. So, starting from the end of 2011 with several meetings, and probably the major meeting happened in the Bulgarian Parliament on the occasion of the World Hepatitis Day last year in May, where the beginning of the creation of the plan was given by the politicians. Following that, a working group was formed, and the working group started working end of 2012. For creation of the national plan. What's the background and the legislation on creation of national plans? It's not a plan that is created by non-government sector and by experts and sitting somewhere on someone's desks. Luckily, Bulgaria has a special legislation procedure for issues that are important and considered as major healthcare needs in the country, and national plans are developed under the health law of the country. So once started this procedure, it's most likely that the plan will be officially adopted and will have proper finance from the relevant institutions in the countries, according to the resource capacity of the healthcare system, of course. So we are planning, and the plan is based actually on the World Health Organization's Prevention and Control of Viral Hepatitis Infection Framework for Global Action, with 4 of the major pillars mentioned in this framework. The national plan really tries to cover all different aspects of hepatitis, and particularly also it's trying to cover issues like compassionate use for hepatitis patients. The expert panel is really wide range. The working group consists of about 30 experts coming from different fields. You can see here medical experts, but also some financial experts, experts from the ministry, and people who really can help with the development of this plan. The administrative procedure, as I told you, it's a special procedure that is listed in the healthcare law, and we have to follow that procedure. But up to now, the working group has finalized the draft of the hepatitis plan. So we are at the end of stage 2. So what follows from now on, the hepatitis plan is to be reviewed by different departments in the Ministry of Health. Then the plan will be put for public discussion in the Ministry's Health site. And then, according to the law, the draft of the hepatitis plan should be consulted with all ministries in the country and finally adopted by the Council of Ministers, which is really high-level recognition by our system. What is the timeline? As I told you, the working group started working end of 2012. Now we have finalized the draft plan of the hepatitis strategy, and we expect it to be finalized and adopted by the Council of the Ministers by September 2013. Implementation to start immediately, together with funding. How is the legislation on compassionate use according to the Bulgarian law? As you heard from Filip, actually member states differ in the ways they are providing compassionate use. According to the Bulgarian law on medicinal products for human use, actually the use of non-registered medicines is not forbidden. However, the procedure how medicines that are not authorized yet actually is determined by a specific regulation that is issued by the Minister of Health. In this current legislation that we have, only medicines that have been approved by EMA can be used within the country. Basically, this means that the Bulgarian patients and the Bulgarian doctors cannot use any medicine that has not been authorized yet by the European institutions. It means that in practice, according to our current legislation, we cannot have compassionate use. And I suppose this is the case in many other countries around Europe. You see how the European legislation allows something, but the local regulations are not always aligned with the European legislation. So they prevent actually the experts of, and the patients of being able to access medicines before the real authorization process. As you've seen in France, this could be 10 to 12 months before the authorization of the medicinal products. So we decided that the Bulgarian hepatitis plan, we definitely have to create a special part that will try to outline some of the issues about compassionate use and to make a proposal for legislation changes. Luckily, this could happen with a simple document and changed by the Minister of Health itself. It doesn't require parliamentary procedure, which could take really long time, having in mind that at the current moment we don't have a parliament and soon we have elections. So what we have put in the hepatitis plan, it's outlined there in phase 1 of the implementation in the plan, a working group on compassionate use to be formed. And this working group has to come out with rules for compassionate use for hepatitis patients. And these rules should be based on medical criteria, expected outcomes, patient safety concerns, of course, informed consent issues, and the whole procedure should be listed in these rules and outcomes that we expect from the working group. Then, the working group should prepare, together with law experts from the Ministry of Health, proposal for change in the legislation on compassionate use of medicines, and hopefully this procedure will be finalized at the end of 2013, when the Bulgarians and the Bulgarian patients would start to be able to use medicines on compassionate use, and those patients who are most in need can benefit of this program. In conclusion, I can say that, as you can see, the two presentations from my country, Bulgaria, and France, regulations on compassionate use differ from country to country. The situation with hepatitis treatment is so dynamic. We expect so different things to come on the market, so different data is coming, that specific guidelines for compassionate use in hepatitis patients is needed. And I really hope that European experts could help us with some guidance, and so also some guidance from the regulators, how compassionate use on hepatitis should happen and facilitated by the member states. And of course, we very well acknowledge that safety data and safety of patients is extremely important. So those guidelines should be based on clinical data and available clinical data for each of the compounds, expected outcomes, and a risk-benefit ratio. Thank you very much for your attention.
Thank you, Dr. Ataseyev, for this really very nice overview, and congratulations to all your efforts you have made in such a short time. Well, before we come into the summary, the last talk is given by a patient with, if I heard it right, a successful compassionate use of new drugs. So I would like to invite Ivan Gardini, he's president of the ELPA in Italy.
Yeah.
So please give me a talk.
So thank you very much. I'm a patient and president of Italian, the most important Italian Liver Patient Association, and also the vice president of ELPA. I would like to share with you my story, what happened to me with the compassionate use program. And this is my personal Vietnam, because it is a battle. This is the exact word. It is a battle with a virus that during 20 years of chronic hepatitis, 5 treatment failed, 3 cirrhosis, and 2 liver transplants. This was a virus that has stolen 20 years of my life, kidnapping mind, body, and spirit, because you can imagine 20 years of illness. It is very tough to support. First transplant I had in 1997 for cirrhosis due to ACV, and the second transplant 11 years later. But after the second transplant, the diagnosis was a cholestatic and aggressive HCV recurrences. That means that I knocked to the doors to the Italian liver transplant centers, and everybody told me that there were no chance. I have no chance, no choice to be retransplanted. That means was living more or less 24 months to live, and that was a very, very dangerous situation for my life. The clinical profile was a partial responder, EL28 CT, widespread cirrhosis, 93,000 platelets. This was very important because the limitation for the compassionate use was 90,000. Under this limit, I was not had no chance to enter in the compassionate use program. Diabetic, immunosuppressive treatment, and was in maintenance therapy, interferon pegylated and ribavirin. This is my pattern of answer to the dual therapy. You know, the viremia decrease, but never get PCR negative, and then the virus after 10 weeks go up again. Luckily, I had the chance to get boceprevir with a lead-in of 18 weeks, so this is. And I got my boceprevir, and after week 2, I had a spectacular answer with 4 log of decrease of viremia. At week 4, I had 5 log decrease. At week 6, my PCR was negative and stayed negative for all the course, undetectable for all the course of the therapy. At the last controls, the HCV RNA was still negative. And it is really good news because technically I have been cured. I mean, I say technically because, you know, when I go to the hospital and I open to see what is the PCR, you know, I'm not so confident still. Was it easy? No, because I had 2 syncopes, many anemia, many neutropenia, so I have to use erythropoietin, growing factors, so with asthenia, dyspepsia, diarrhea, pruritus, so many side effects. But now, what's the sensation? The sensation is that after 100 HCC interferon injection and 600 and how many pills, you know, I have purchased the return ticket from hell. So this is the feeling. So I can say, and I'm sure, totally 100%, that the early access with compassionate use may save the life, and patients are back to life. This is many people love this picture because it's no words but a lot of significance. It's me before and it's me after. And this is with my daughters in a disco, so I'm back to life, totally. So what I want to say that each year from 5 to 7% of patients with compensated cirrhosis progress to decompensated cirrhosis. In these patients, all drugs, regimens based on pegylated interferon, ribavirin, and other DAs cannot be used due to several side effects and contraindication. Those people will face liver cancer, liver transplant, or death, which dramatically increase the patient suffering, the family suffering. It is also a social economical cost. Registrative trials, clinical trials, expanded access programs and also compassionate use have several exclusion criteria, as I mentioned before. Below 90,000 platelets, I was not accepted. That means close the door to the patient most in urgent. For those patients, the question is, wait for total safety data or open a risky window to the early access? This is the bottom line. So what we ask for is to remove from compassionate use protocols most of the exclusion criteria that might lead to exclude patients with ACV advanced disease, especially with this all-oral therapy. Many side effects are less. So there is no more reason to keep so high the exclusion criteria. This regards the compassionate use and the named patient-based programs. Second, the right of the patient to have curative choice, even taking some risks, with European Regulatory Agency to issue opinion on the subject. I like very much something told me some time ago, my friend Luis. He said, we want to die with dignity, or we want to try to die with dignity. And if we have a choice to risk, and we have a doctor that is agreed to treat, to take some risks, we don't know why we cannot be treated. We cannot take this risk. It's our life. As third, and we hope that could be set up an European register for the result of curative DAs combination given by compassionate use. We need this kind of European register. And a common, of course, a common legislation approach of member states, particularly on compassionate use programs for HCV patients. Thank you very much.
Well, thank you, Mr. Gardini, for this very well-perceived and moving presentation. And before we starting the discussion, I would like to give a kind of a summary from what we have heard and what are the advantages and probably disadvantages of the programs and the situation we have so far. So I think it is quite clear, and you have heard that in the middle of all our considerations with respect to compassionate use in Hep C is the patient. And really the patient who cannot wait, and I think you have seen a typical example, especially with this cholestatic hepatitis occurring after liver transplantation, where the risk of death is really very high within sometimes even weeks. Nevertheless, and this was a case you have seen, we need some information of an effective antiviral regime. It's not only some drugs around, it's also a knowledge how to use them, what is the optimal duration, and all these things. So I think that's quite clear. And this was the case with the boceprevir triple therapy you have seen. I think we need some information on the safety profile. And also this was quite nicely mentioned in the recent case, or in the case presented immediately or just a few minutes ago, that you need addicted and specialists and very specialized physicians in order to have these programs. We need some way, at least if we do it not on a patient basis, of monitoring of safety efficacy, and in this respect probably also a kind of a review board. But nevertheless, I think there's legislation and we have to stick to the rules. There's no way out. There are regular things we have to consider, and it could be that we try to change some of these rules, and this is one reason why we are here. And on the other hand, we have the companies, we have the pharmaceutical industry, and they must be willing also to offer these drugs. So let me come to these different points that are very important in the setting of compassionate use for hepatitis C. So who cannot wait? And as we also have seen from Massimo Puotti's talk, it's not so easy to give really a very good definition, and even in patients with compensated or in liver cirrhosis, some of them can easily wait for, let's say, 1 year, 2 years, or even more, so you can follow and can look at them. Then I think we should really be sure that all potential treatment options are exploited. And my feeling is that quite often there are regimens where experts feel that they may help for a single patient, but they are off-label, that they are not used, and I think this can be also a way to improve patient care. What about the access to ongoing clinical trials? So this could be probably organized by patient organization, tell you here for your special situation is an ongoing study, you can be included. So collaboration and advice from patient organization would be quite helpful in this respect. On the other hand, we have patients being really intolerant to current therapy, and this could be also a definition for patients who cannot wait. And on the other hand, I think if you look at a kind of a broader compassionate use and not on a based patient-to-patient decision, nevertheless, the compassionate use must be in a way restricted to a limited number of patients, and we have to discuss what these numbers are. The second point was the effective antiviral regimen, and here's again what's the definition of an effective antiviral regimen. And I think most of all would agree that a phase 1 trial is not enough to show that this is an effective antiviral regimen. We need at least to have phase 2 data and probably a regimen established that is put forward into phase 3. So that we are more or less sure how we have to combine different drugs, or for how long we have to use them, and for how long they are safe, and so on. And I think there should be showing that there's a clear advantage over the current licensed regimens. And this can be quite problematic, that there should be some efficacy data for patient population considered for compassionate use, at least preliminary data. So what about the safety profile? Here again we have some definition issues. As I mentioned, we should have at least phase 2 studies, and then it depends really on the compound or on the regimen, whether the likelihood for adverse events and the risk or the risk-benefit ratio is quite low or quite high. And this can be judged from some pharmacology data you can have on these different type of drugs, whether it's interferon containing or not. You all know these different aspects. Sorry, here went the safety profile. But we have the problem that I think it would be very nice to have some safety data for a patient population considered for compassionate use in the same way as we were looking for some efficacy data in these studies, and we have to mention drug-drug interactions, and especially those who cannot wait are quite often those patients also having comorbidities, as you have seen. That could be patients after liver transplantation taking a lot of drug, probably have other diseases, and these comorbidities have to be considered. So what are the concerns? The concerns are that patients who cannot wait are normally not part of phase 2-3 trials, and a potential solution is that we should target special population with increased morbidity and mortality risk early during drug development programs to get some of these early data for these patients. The other point, and I think this should be clearly addressed, that there are toxicities associated with new drugs, and we should not underestimate these drugs. Many drugs failed after having good data in early phase 1 or phase 2, and then coming to phase 2b or even to phase 3, and these can be severe. And just to give you an example of a polymerase inhibitor for Hep B, it's many years ago where there were deaths due to mitochondrial toxicity. We saw deaths on pancreatitis in the phase 3, and there are polymerase inhibitors associated with severe lymphopenia, and one patient in France died. This was during the phase 2 program. And you have seen the data on the early access program, also showing that probably physicians were not as best trained in the use of these different compounds. And more in general, there are safety concerns that if you have a really high liberalization of the use of not approved drugs that can be really in uncontrolled use, there might be rare side effects, especially in special population. We do not have a lot of experience in potential drug-drug interactions, and as I mentioned, physicians may not be well trained to use the new drugs, and at the end, an improper use may lead to resistant development and so on, and this may negatively impact future treatment options for the individual. Coming to the specialist again, who should be part of this compassionate use program, and I think this cannot be for the general physician. So I think the person using these drugs in being part of a compassionate use program must be specialized in some way. So we have to define them. It could be a definition of long-term experience in managing the corresponding patient population, some experience with a new regimen, probably being a study investigator of these new drugs, and working in a specialized center where, if there are any adverse events or severe adverse events happen, you have all the facilities needed to manage the patient. Well, monitoring and the review board, when you have this compassionate use, I think it's quite useful to have a kind of a protocol, to have a definition of your patient population and some inclusion-exclusion criteria. You have to see how to monitor and to report the data. So in conclusion, ladies and gentlemen, new drugs, we need and we have new drugs, and they should be considered if they have a favorable risk-benefit profile. We need a definition for patient with the most urgent need. We have to collect data and experience of treatment in these patients, at least some safety data, drug-drug interaction data, and we have to draft a document. We need the position of the patient, the industry, the physicians, the regulatories, and if everything looks safe, we have to consider the program, but at the end we have to comply with the country-specific legal rules, as you have also seen in Hungary. So thank you very much for your attention. I thank all the speakers for excellent talks. I think we have enough time for discussion, and I would really like to welcome you to go to the microphone, probably introduce yourself and ask our specialists. So thank you very much again, all the speakers. So who's first, please?
Thank you. My name is Teresa Casanovas. I'm coming from Barcelona, and I am a doctor. I am a specialist, and for more than 20 years I am treating patients in liver transplant, hemodialysis patients, and some of these patients never will have, and we will never have, controlled randomized trials. So if we had to wait, we will wait and wait. So I think I am very grateful for this meeting, and especially for the experiences of the patients. And when the patient Luis said that we have to work together. And some considerations I have. The first is, in my opinion, we have to avoid the word compassionate use because could be misleading. I think perhaps other definitions could be better. For example, off-label, because off-label means we have to avoid this not approved drug for a specific indication or a specific population. I recommend some articles, one article in Mayo Clinic Proceedings about off-label drugs, because a lot of examples, and especially for the pediatric populations, they use off-label thousands of times, and some uses, even in our specialty, are not controlled trials, and you use some established protocols in our population. Another thing is the empathy. We have empathy for the patients, but it's not only the emotional empathy, the sympathy, but we have to take an active role with the empathy, because if it's only the level of the empathy in this meaning is not enough, and we are doctors and we have to help the patients. Also, I need more collaborative work, and this is urgent, and we have to imitate countries with a good position. For example, France. I think the CUPIC program perhaps has some failures, but I think it has been very important. And now the example they have two programs very important: the patients who are waiting for liver transplant and patients after liver transplant. We can have access to treatment without interferon. Thank you.
Well, thank you very much. I think these are a lot of comments, but probably some of you would like to answer these questions. So, Mr. Josephson.
I have two comments. Firstly, I entirely agree with the point made by Dr. Berg and also by you, that the more trial-like a compassionate use program is, the better. I mean, and CUPIC is a very good example of a compassionate use program or expanded access or whatever you want to call it, where clearly very important data has been generated. Second, I just want to clarify some concept. Off-label use for us is use of an approved drug for an indication that, or if for a patient that does not fulfill the criteria of the stated indication. Whereas a compassionate use program, by definition, would be pertaining to a drug that is not yet approved. I think it's important to make that distinction.
Yes, Professor Dhumeaux.
The definition of compassionate use is treatment without investigation, in the definition. Our definition. This definition is not good. And we have now the experience of CUPIC. CUPIC is a trial. Is a trial associated with early access program. You see the point. The early access program is not investigation. And after the success of CUPIC, I would propose to the Minister of Health and Agency for the Safety of Drugs to systematically combine investigation plus early access program. The cost. But we could have, like in CUPIC, very useful information coming from these compassionate use in association with pharmaceutical company, and probably associated with independent committee from the company for the investigation. You see the vision, but I'm not sure this could be accepted due to the cost of that. And you have an agency of research, the INRS in France, who is particularly involved in this clinical investigation. But this could be nice to have such evolution of the compassionate use towards the association with investigation.
Would you like to comment on that? No. Then the microphone.
Hello, my name's Tracy Swan. I'm a treatment activist from New York City, and I know this long pad looks very scary, but I have a few brief comments that sort of lead to a question. Now, clearly there is a relationship between clinical trials and these compassionate use programs. And in HIV, we saw a field that moved as it matured from development of first-line regimens in treatment-naive people to the development of regimens specifically for more advanced drug-resistant people, salvage therapy, etc. And we're in a field that's moving very, very fast right now. I think we can all agree. And we're seeing a lot of people getting cured in these trials, some relatively easy to cure than others. So this makes cirrhosis, in my mind, both the proving ground for a drug. Can that drug be safe and effective in people who really, really need it? And a frontier. And I think it's becoming a little bit too much of a frontier. Sound C2, a phase 2 trial where people with cirrhosis were also enrolled, is a great example of providing data that can inform trials and programs like CUPIC, which was fantastic. And I'm just wondering, how do we get to more trials like that? Because if you look at it, given the limited resources, the people who are most likely to be treated first are the people who need treatment more. So how do we get to that more easily and then branch out to where treatment is more necessary that might not be a conventional registration trial? Thank you.
Thanks a lot. Who would like to comment? Massimo, do you have a comment on that?
I agree completely with this comment. I think that there are some trials explore pushing the envelope and including patient. For instance, the trial on Sofosbuvir included patient with less than 90,000 platelets because of the characteristic of this drug. And I think I strongly agree with it, and I strongly agree that maybe at the European level, there is the experience of ATU, the experience of CUPIC should be taken at the European level, probably, because each state maybe can collaborate, giving his own database, putting the database together, and this will give us immediately, as soon as possible, information, especially with this treatment with a shorter duration, some of them. So the possibility to obtain this drug, to try this drug in some context, will give a good opportunity to have an increased advancement in our knowledge. And this only with a European network. The French numbers are very high, but I think with the European network, the numbers will be so great to give us the opportunity to learn as soon as possible how to use these drugs in patients with the most urgent need.
Okay, please.
Hello, Pascal Mella. I'm the president of the French Association of Patients SOS Hepatitis. I would like to. I'm very happy because I heard the word war, battle, and dignity. It's very important for all the patients. The patients say we are not animals. We want to be a soldier to fight. I prefer to die in fighting against the virus and not to die waiting for a new treatment. And I want to choose what I want to do. It's very important for all the patients. I want to remember you a very important thing. Against hepatitis B, 10 years before, a lot of patients died on waiting transplantation. We have a French authorization for new treatment, and we can save a lot of patients and don't transplant patients, and they are still alive. And they control the virus infection with treatment. But we have the strategy to give the treatment before transplantation. And I'm not agree with the decision today. Sofosbuvir can be used after transplantation for 5-6 patients in France. It's not the good time. And if you say compassionate access, when is good time? It's not after the transplantation. It's before, I think. And remember the past. It's very important for the future. And if you speak about compassionate access, we must have in our mind the compassionate access for drug against hepatocarcinoma, because it's the same thing for us. We need this drug.
Well, probably before the panel asks, I really agree that treating those patients being on the waiting list where we have the chance probably to avoid transplant would be really a big opportunity, and we have to try to reinforce it, or at least to ask for a patient on a patient-based way whether we can get these drugs in advance. I think for some countries this is probably not anymore a big thing because they will become available quite soon, but for other countries, of course, the situation is quite different. And who likes to answer? Or yes, please.
I think that it's non-ethical at this moment with the results that we have and that many of us know, not to make a study across Europe and probably in other places for the people on the waiting list. And remember that in my country, for instance, and many other countries in Europe, being on the waiting list is also being on the death row, because we have 10% of the people that are in the waiting list that do access transplantation, and in some countries there is not even transplantation. So I think that it's non-ethical not to do
these studies are running, but limited number of
yes
can be included, of course.
And just another point that I think that the community of patients, but also the physicians, need to take into consideration is that we have, as Aristotle said, the horizontal equity and the vertical equity. And I'm afraid that we have a big business in front of us that will try to cure at very high costs, very easy to treat patients that could wait. And in many countries, I probably say that in France or Germany will not be the case. In many countries, there will be the patients in most urgent need that will not have access. Also, the others will not have access for now. So there is a kind of emergency. There are patients in European clinics that needed to have access, that could benefit from the access, and that will not have it, because there is a strategy for a different model that I think we should not agree. That's my thinking.
Are there other comments? Well, before we come to the next question, just probably one reminder. I think we have to face the truth that in many countries there will not be, due to limitation of the money, let's say, that there will be a broad access to all these new treatments. And therefore, the early detection of the infection and treating in very early stages of diseases, even with interferon and ribavirin, you can cure a number of patients, and this will have a significant impact on the overall mortality, and this can be clearly ruled. So probably we were a little wrong in 20 years ago to consider treatment only for those being very advanced, or this could be also a strategy in order to prevent a lot of decompensated or a lot of number of patients being decompensated and entering the waiting list. But probably it's a direct comment on that, or okay, so 1 second please.
Just a comment on the availability of those drugs that we expect. It's clear that they are not going to be available in every country, because we can see that with the triple therapy. Even without the European Union, even without within a country like Italy, you can see that from region to region the availability of these drugs really is different. But what I would say, we live in a globalized world. We live in United Europe. Even yesterday there was a report, I think, from Scottish doctors that it was proved many cases of Scottish people traveling to Bulgaria, Romania and Poland for dentist services being infected with hepatitis C. So my point of view is that we have to find a way to assure access everywhere in Europe. We cannot close our eyes, because the problem simply doesn't stay in Bulgaria if Bulgaria doesn't have treatment. It simply doesn't stay in Romania. It spreads, it comes to Germany, it comes to France, it comes everywhere. So I'm sure that we have many problems from now on to face, like pricing issues, access, economic crisis and things like that, but we have to be innovative because we don't have any other chance. All patients